It's my pleasure to welcome you all to this seminar today, one of the seminars organized by the Wiskott-Aldrich Foundation to increase knowledge and interactions between physicians and patients and families affected with the Wiskott-Aldrich syndrome. Today, we are very lucky to have Dr. Francesca Ferrua talking to us. Francesca had her training in medicine. She got her medical degree in Milan at the University of Vita Salute San Raffaele, where she also got her specialization in pediatrics and a doctorate. Doctorate in Italian is something similar to a PhD in molecular translational medicine. Currently, she is a staff pediatrician at the University at the San Raffaele institution in Milan. But you all know her because of her extensive investigations in the Wiskott-Aldrich syndrome, especially in development and application of the gene therapy for this condition. So today she will tell us about her work and the results of this procedure as alternative therapy for the Wiskott-Aldrich syndrome, and she will be then try to answer as many questions as we can at the end of her presentation. Francesca, without further ado, please.
Dr. Ferrua, can I just take 1 second, please, to
Yes, of course.
just do some housekeeping. Before Dr. Ferrua presents, I just wanted to share that the information that's presented in the session does not substitute the medical advice or treatment suggestions from your child's physician. As we all know, each of our children, our patients are unique, and the information presented in the session may not be applicable to each one of our patients. So make sure you consult with your doctor and do not disregard any medical advice from your physician or delay seeking treatment based upon the information that Dr. Ferrua and Dr. Kendati will present today. Please mute yourselves, and this session is being recorded, so feel free to turn off the camera and my apologies. You are allowed to use AI Assistant if you wish, and please turn off your cameras if you so choose. And without further ado, Dr. Ferrua.
Thank you, Sumati, and thank you, Professor Candotti, for the kind introduction. First, I try to share my slide. That is the most difficult bit. Okay. Can you see my slides?
Yes.
Perfect. So, today, I would like to provide you with an overview about the status of the art of gene therapy treatment for WOS. And I'm sorry if I will use some medical words, but I will try to provide a comprehensive overview, and I would be very happy to answer your question at the end of the presentation. Okay, good. This is my disclosure slide. And of course, I know that you all know very well what Wiskott-Aldrich syndrome is, but I would like to start my presentation from this very important concept that was demonstrated in a very nice retrospective survey that was published a few years ago, in which data from more than 1,500 WOS patients were collected, and the group of Bali et al. Nicely demonstrated that the genotype, so the WOS disease mutation, is a predictive biomarker of disease severity. You all well know that the WOS is a disease with a very large disease spectrum, with a disease severity that can go from mild WOS, that historically was called X-linked thrombocytopenia or XLT, going through classic WOS characterized by the triad of thrombocytopenia, eczema, and infection, and in most severe cases, but also by autoimmunity and malignancies. And we know that disease can progress over time. And from this study, they demonstrated very nicely that by grouping patients with by their class 1 or class 2 mutations, so being class 1 mutation variants in the WOS gene in exon 1 or 2, or an intronic variant in exon 6, and naming class 2 all the other variants, they demonstrated that overall survival is better in patients with class 1 variants, but also in these patients, disease-related events can occur. So also patients with the less severe variants can experience a later onset of disease-related complication. So also then they remain prone to morbidity and premature mortality. And this implied a more recent consensus on the fact that all patients with WOS, also those with initially mild phenotype, should be offered a definitive therapy in the form of either allogeneic transplant or gene therapy because of this risk of progression over time. And the factors considered for definitive therapy are basically disease severity, the age of the patient, the donor match, their organ function, and also the patient and family preference. So at the moment, the current management approach for WOS is based mainly on supportive treatments, mainly aimed at preventing disease-related complication, in particular prophylactic antimicrobials for preventing infections, immunoglobulin replacement therapy, and bleeding prophylaxis, mainly based on platelet transfusion in case of traumas or surgery. Increasingly, off-label TPO agonists are used, especially as bridge treatments before more definitive approaches such as HACT or gene therapy. Splenectomy is currently no more used because of the, inherent risk, infection risk, but historically it was used to prevent, try to increase platelet count. Then there is the treatment of immune dysregulation in patients with autoimmune or autoinflammatory manifestation. But the standard curative treatment has always been allogeneic hematopoietic stem cell transplantation, which has which can cure the disease, and also results have been improved over time in the last decades, but is still hampered by limited donor availability and potential complications such as GVHD, rejection, or autoimmune complication. And age above 5 years remains a risk factor for overall survival, also according to more recent literature. For this reason, being current approach is offering limiting choices for patients, and this has been a driving force for the need for new therapies. And for this reason, in the past 15 years, alternative treatment option represented by lentiviral gene therapy has been extensively studied. In particular, since 2010, multiple clinical trials have been performed in Milan, but also in Paris, Boston, and London. And a common point of these trials was the use of a self-inactivated inactivated lentiviral vector that was the design was similar in all the trials, but the cells were manufactured, the vector were manufactured at different sites. Across all these trials, sorry, I see appearing a line on the slide, I don't know why, sorry about that. Across all these clinical trials, what we have gained is the proof of concept of this treatment because patients experience an excellent survival. Here is a reported recently published summarizing table with the results from different trials with a total of 47 patients. Survival was excellent including all the patients, was 94%. 3 patients who died because of disease complication not related to gene therapy. In 2 cases, they were infections, and in 1 case, is a deterioration of underlying neurological condition. In all surviving patient, immune function significantly improved, and patient experienced a reduction in severe bleeding events, thanks to improvement of thrombocytopenia, and importantly, no lentiviral-related adverse events or clonal expansions were observed so far. Difference between the trials conducted in Milan and the other was the use of reduced intensity conditioning regimen. That was a choice that was based on the fact that in Milan we aim to reduce toxicity related to conditioning regimen and also to exploit the survival advantage of gene-corrected cells, while in the other trials a more intense conditioning was used. Also in Milan, all the patients received a single dose of a monoclonal antibody, anti-CD20, that is rituximab, with the aim to deplete potentially autoreactive B cells, and also as a preemptive treatment for ABV infection in patients which were ABV positive before treatment. So this was an overview on all the trials performed, but now I will focus my presentation on Etuvetigene autotensel. That is a gene therapy product developed at Stiget Institute in Milan. That is composed of autologous CD34 positive hematopoietic stem progenitor cells transduced ex vivo with a self-inactivating lentiviral vector encoding human WOS-cDNA under the control of a reconstituted promoter from the human endogenous locus. The vector and drug product were manufactured at an FDA-approved CDMO in Italy. And Etucell was recently approved by both European and US regulatory authorities, named EMA and FDA, under the trade name of Woskira. And the particular aspect of gene therapy mechanism of action is that it directly addresses the genetic defect underlying WOS through lentiviral gene transfer. Basically, to summarize the treatment, in gene therapy, there is no need of a donor because the patient's own hematopoietic stem cells are harvested originally from the bone marrow, now from mobilized peripheral blood. So patients receive mobilizing agents, namely G-CSF and plerixafor. After a few days of mobilization, patient stem cells are collected through leukapheresis. From this collection, a portion of that is not manipulated is stored as a backup in case of future needs, and the other portion, that is the majority, is sent to the manufacturing facility where cells are purified, cultured, and transduced with the lentiviral vector. After transduction, cells are cryopreserved and they undergo extensive quality check process because you have to know that this is a very complex process. The cells are produced and corrected under GMP, and it's important to have all the information about the drug product that is gene-corrected cells before starting conditioning and infusing them back to the patient. This process requires basically 5 to 6 weeks. In this period, the patients they are central line position. They receive rituximab roughly 3 weeks before infusion of a gene therapy product. And after receival of quality certificates in which treating physician can see if the cells are enough, they are properly collected, they are sterile. Conditioning is started, and conditioning is made by reduced intensity, so non-myeloablative dose of busulfan and fludarabine. Conditioning lasts 2 days. And then there is a day of rest. And on day 0, cryopreserved gene-corrected cells are thawed and infused back to the patient. After that, the hematopoietic stem cells which have been gene corrected. They engraft in patient bone marrow, and they give rise to all blood cell lineages which bear the corrected WOS gene. And so the clinical follow-up aims to check the reconstitution of hematopoiesis and immune function. Sorry. So the clinical developmental program of A2-beta autoimmune cell was based on data collected from 27 male subjects diagnosed with WOS, which received treatment between 2010 and 2022. First 17 patients received a fresh formulation of the A2 cell between 2010 and 2019 at San Raffaele Hospital in Milan. First 8 in the context of a phase 1/2 clinical trial, then additional 9 patients were treated in an expanded access program. Then there was a phase 3 clinical trial aimed to prove the efficacy and safety of the cryopreserved formulation of A2 cell, in which 10 patients were treated. 9 patients were treated in Milan. 1 patient was treated in Atlanta, in the US, at the Children's Healthcare at Emory University. And then all these patients are currently followed up in a long-term follow-up study. So the data from these 2 clinical trials and expanded access program have been integrated to study the safety and efficacy of this treatment approach. And basically, very quickly, the primary efficacy endpoints were overall survival, the rate of severe infections, comparing the period from 6 to 18 months after gene therapy with the year prior to gene therapy, and the rate of moderate or severe bleeding events in the first 12 months after gene therapy were compared to the rate of these events in the year prior to gene therapy. Then we analyzed a list of more biological and lab efficacy endpoints, and importantly, we also analyze all adverse events for safety purposes. And there were also a list of sub-analyses analyzing results by age group, baseline disease characteristics, cell source for gene therapy, DP formulation, and so on. So this table aims to summarize the features of the patients treated within this clinical developmental program. Median duration follow-up range between 1 and up to 13.3 years, with a median of 5.7 years of follow-up. Age at treatment vary between 1 and 35 years. And with 33% of patients were treated at age above 5 years. And 2 subjects received treatment as adults and were splenectomized early in their childhood, so before gene therapy. HSPC source was bone marrow in 5 patients treated in the first clinical trial, and mobilized peripheral blood in the rest of the cohort. And as you can see, ZU score varied, gene therapy varied between 2 and 5A. All patients receive an adequate dose of CD34 positive cells per kg, and median vector copy number in the drug product was 2.3. Sorry, okay. Focusing now on the safety of gene therapy treatment, in our cohort, overall survival was 96%. 1 patient died 4.5 months after gene therapy due to the deterioration of a pre-existing neurological condition that was considered unrelated to gene therapy by the investigator. To date, we had not recorded any reports of gene therapy related adverse events, no serious no related or adverse events or serious adverse events, and no suspected unexpected serious adverse reactions. We had no evidence of any insertional mutagenesis or abnormal clonal proliferation or replication-competent lentivirus, and no subjects generated a detectable antibody response to WASP. Overall, The adverse events that were recorded following treatment with Etu-cel are consistent to what is expected in host patient undergoing hematological and immunological reconstitution after reduced intensity conditioning and are not indicative of any specific risk related to the drug product. Engraftment, we did not record any SAE related to mobilization or leukapheresis procedures. We had no engraftment failure after Etu-cel infusion, so no patients needed to receive their autologous backup infusion. No patient experienced GVHD, and also there was no need to perform any secondary procedures after gene therapy, such as allogeneic HSCT or splenectomy. Most of the serious adverse events occurred in the first 6 months after treatment, and they were mainly infection, most frequently CVC-related infections. And from the efficacy point of view, we managed to demonstrate that sustained engraftment of gene-corrected cells was confirmed over time, both in the bone marrow and peripheral blood of cells, and the gene-corrected cells represented by these lines. I know that is a bit difficult, but the important I would like to stress is that the level of gene correction remains stable over time up to the latest time point. And as expected by the advantage of gene-corrected cells in the lymphoid lineage, we got higher levels of correction in the lymphoid cells. And this led to the restoration of WASP protein expression, both in lymphocytes and platelets. That also was stable over time up to the latest follow-up time point. This led to immune reconstitution with increased T-cell proliferation response to stimulation with anti-CD3 antibody that was observed at 1 year after gene therapy and was maintained over time. And this resulted in a substantial reduction of severe infection after the first 6 months of follow-up that was maintained over time up to the latest time point. And this was true also if we see the results by patients. These gray bars represent the length of the life of each patient, either before or after gene therapy, and the green squares are the severe infections, and you can see the difference between the before gene therapy and after gene therapy periods. And also, patients, thanks to immune reconstitution, were able to stop sustained immunoglobulin replacement therapy and sustain antimicrobial treatment after gene therapy. And also, they were able to start vaccination schedule after gene therapy after at least 6 months after last immunoglobulin administration. And most of them were able to mount a protective response to most of the vaccinal antigen tested, including live attenuated vaccinations. Moving to platelet side, 96% of patients at last follow-up had a platelet count greater of or equal to 50,000 per microliter. And this increase in platelet count together with the improved platelet function and morphology, and also thanks to the normalization of the volume of platelets, led to protection of patients from bleeding events. In particular, after the first 6 months of follow-up, we observed a drop in the rate and in the severity of bleeding events recorded in patients, and also patients were able to stop sustained platelet transfusion after treatment. And protection from bleeding was also confirmed at a single patient level. And as you can see here, the green the red symbols represented the bleeding events before gene therapy, and after gene therapy, you see that the red spots are much fewer. Focusing on other disease characteristics, also we do not have to forget eczema that resolved in all treated patients. Also immune dysregulation, including autoimmunity and autoinflammation, improved in most patients after gene therapy with no need of prolonged immune suppression after treatment. And as you can imagine, quality of life improved in all patients after gene therapy, in particular as shown by the normalization of social life, meaning no need to living in a protected environment anymore, being able to attend school or kindergarten or having a job according to age, and also participating in sports activities. Hospitalization rate declined after the first 6 months after infusion of A2 cells as the number of days spent in hospital. So based on all these results, A2 cell became the first gene therapy approved for the treatment of WOS, both in Europe and in the US at the end of 2025. And the indication for treatment with A2 cell is the treatment of pediatric patients aged 6 months or older and adults with WOS who have a mutation in the WOS gene and for whom hematopoietic stem cell transplantation is considered appropriate and lacking a suitable HLA match-related stem cell donor. Before concluding, I want to provide you also further updates because after the closure of the second clinical trial, we were able to keep treating patients thanks to an Italian law that allows you to give treatment before its official approval based on demonstrated safety and efficacy. So we keep treating patients in this early access scheme, and we treated the 6 patients between December 2023 and May 2025. Their median age at treatment was 2.3 years. Of course, they have a shorter follow-up as compared to the cohort I just described you, but they are currently all alive and well. We also in this smaller cohort, we have not observed any gene therapy-related adverse events. So safety and efficacy data so far are in line with previous patients treated with A2 cell. But importantly, in this cohort, we observed the platelet count above 100,000 per microliter since after the first 3 months of follow-up in the first 4 patients treated. And in this cohort, there was also 1 patient which was treated with gene therapy after it rejected 3 previous allogeneic transplants with no residual cells of donor origin. I have to say that this patient, before going to gene therapy, received the infusion of his autologous backup to save him from aplasia and concurrent post-transplant complication. And 1 year after infusion of autologous backup, we could collect his own stem cells, transduce them, and treat him with gene therapy. This is very early, so we are following up at the moment. And very preliminary data on these first 4 patients treated in this early access scheme confirmed the stable and robust engraftment of gene-corrected cells both in bone marrow and peripheral blood. We did not detect any bleedings after gene therapy. Also, infection rate decreased with no severe infections after the first 6 months of follow-up. First 3 patients were already able to stop immunoglobulin replacement therapy between 10 and 14 months after treatment, and they started the vaccinations thereafter. Eczema improved in all of them, absent after 1 year of follow-up, and the previous clinical manifestation of immune dysregulation resolved after gene therapy with no recurrences. And 3 additional patients were treated between August and December 2025, but their follow-up is too short to be presented. So in summary, as you all know, WOS is life-threatening disease, and A2-vetidegene totem cell is a one-time autologous ex vivo lentiviral hematopoietic stem cell gene therapy intended to treat the underlying genetic defect in patients with WOS who lack a suitable HLA match-related donor. Results collected so far demonstrates a favorable benefit-risk profile with sustained long-term significant clinical benefit. I forget to mention that outcome was similar across different ages, disease characteristic, WOS mutation, and the drug product formulation. And also, HUCell is the first gene therapy approved by both EMA and FDA for the treatment of WOS, and also the first to be licensed by a no-profit organization. Before concluding, I would like to thank my mentor and the PI of the clinical studies, that is Professor Alessandro Aiuti, and all the team in Milan who participated in all the clinical trials and the treatment of the patients, and also our colleagues in Atlanta and the referring physician and collaborators, but also all patients and their families who trusted us, and also all of you for your attention, and I would be happy to take any questions.
Thank you very much, Francesca. Thank you also for giving us these updates on the very recent results that are really, really encouraging. And I want just to try to follow up with one question, given that you just mentioned this exciting results about the platelet numbers in the last patients that are all above 100,000, and people that have followed this field, they know that there is this discussion in terms of the efficiency of gene therapy for platelet numbers, platelet function. In this case, the new results, or the recent results, would indicate that there is no difference between gene therapy and bone marrow transplant. Was there anything different in this last series of patients compared to the previous ones, where you told us before that most of them have an average of 50,000 platelets?
Thank you very much for the question. Actually, the drug product has not changed. I think that one factor is that we observed the higher platelet count in patients receiving mobilized peripheral blood-derived HSCs. But actually, in the end, I think it's just a matter of kinetic, because also the first patients treated with the bone marrow-derived stem cells at a lower kinetic of platelet increase, but then in the end, on the longer term follow-up, they reached platelets above 100,000, more or less. So actually, median platelet count, sorry if I was not clear, is higher than 50,000 per microliter. That was just like a cutoff above which 90% of patients were. At 5 years, in the clinical developmental cohort, the median platelet count at 5 years of follow-up is 70,000, the median, ranging between 48,000 up to 228,000, or less.
Okay. So
I think that the drug product did not change, so there are no differences. I think that something apart from the stem cell core source, something that improved in the most recent years was that we could manage better, like other factors, such as, for example, CMV. CMV infection was management improved in the last years as compared to also 6-7 years ago. We are using letermovir in prophylaxis for the very early follow-up. That is not like myelotoxic, and we are having good results with it. So we are not experiencing any more like reactivation in the very early follow-up, and we try to control CMV much better also when we collect the cells. This is not something demonstrated, it's just a personal opinion. So since I had the fortune to see all the 15 years of the trial, so this is something that has been improved thanks to the improvement also of the availability of the drugs. And basically, that's the only factor. I cannot think of anything else. So,
specific.
Yeah.
Yes, but with everything in medicine, the more you do things, the better you get at them, and therefore it makes sense that in the recent results things are getting better, and I'm sure you will continue to do the same way, so to improve even more. So as you know, we received more than 50 questions from patients that have sent them in. They are divided into different topics, different areas. I'm going to ask you a few questions from all of these areas just to try to get to as too many questions as possible. There are some questions specific to the procedure, and the question regarding the intensity of chemotherapy, what are the toxicity of that, how long does the process last, how long does a patient need to be in the hospital, and how long the follow-up should be.
Yeah, actually, I prepare a backup slide about this, if I can retrieve it. Sorry, because that would good to have it to answer. Let me try if I... Okay. Can you see this slide about patient journey?
Yes.
So just to provide a practical overview, because I think that for families is very important. So first step for is to understand if a patient is eligible to gene therapy treatment. So this implied like review of medical records, I mean, a standard process for indication to a treatment. Then there is a phase for patient's workup, because before treatment, that is very similar to what is performed before HACT, because you have to perform intensive biological infection screening, instrumentals, and so on. One peculiarity of gene therapy that we also always perform a bone marrow aspirate before treatment, because we have to check that there are no alteration in bone marrow hematopoietic stem cells, like for example signs of myelodysplasia or other alteration that can prevent to use cells for drug product manufacturing. Then there is a first hospitalization for mobilization and collection of HSPCs that lasts basically 1 week, some also a few days less. Usually the cells are collected in 1 or 2 rounds of leukapheresis, depending on the yield of the collection. Then there is another short hospitalization for central line positioning and rituximab administration, which lasts a few days. And then usually patients are admitted in a BMT unit on what we call day -5, so 5 days before infusion of gene therapy. And the conditioning regimen lasts between day -4 and -2. The dose of the medication used, just to make it easier to understand, are kind of half of the dose that is usually used in the standard myeloablative conditioning in the HACT setting. In particular, busulfan is given at a standard dose based on the weight of the patient. Then we perform 2 rounds of pharmacokinetics. So basically we measure the level of the drug at different time points before the infusion of the busulfan and the same time points afterwards, because we want to target the exposure of the patient to busulfan at a certain level that is kind of half of the target that is used in bone marrow transplant. And because we don't want to give too much toxicity, but also not to give sufficient myeloablation, because we need to make space in the bone marrow for gene-corrected cells. And also fludarabine is given in 2 doses. And I have to say that these medications are very well tolerated by patients. We usually, what we have seen is some mucositis, not usually moderate. Only few patients required TPN for some days. Patient may require some painkillers, but nothing really bothering too much. Yes, a patient experience alopecia, that I know that from the psychological point of view is not a good thing to experience, but is transient. All patients experience neutropenia, severe neutropenia because of the myeloablation, but it's transient. It lasted more on a median of 2 weeks. In these 2 weeks, the patient is kept in the cubicle because the infection risk is very high, but usually neutrophil engraftment day is around day plus 22, and after that they can be discharged. The length of the hospitalization in the BMT unit is usually 3 to 4 weeks, unless some complication may occur. Sticking to toxicity of chemotherapy, we observed some increase in liver enzymes, but nothing really serious. Only one patient experienced a VOD, but he had an unexpected high exposure to busulfan due to probably personal single patient reasons. But then after that event, we modified the PK studies in order to prevent these unexpected exposures. And after that patient, we did not experience any more similar cases. On the long term, of course, we need to monitor for secondary tumors, maybe related to chemotherapy. We had a case of thyroid cancer at 5 years of follow-up that was demonstrated not to be related to gene-corrected cells, but that is a cancer that is known to be associated with chemotherapy, but in that case, that patient also required for his disease multiple lines of immunosuppressive treatments over many years. So that could have been that could have had a role. And we don't have yet data about fertility because it's something that is interests us a lot. So we are collecting data, but our patients are most of them are too young to study it properly. So we don't have an answer about that. Sorry if I talk too much about that size of chemotherapy, but I think that is important. So on day 0, patients receive infusion of the drug product, usually preceded by an antihistaminic drug to prevent potential allergic reactions, and then is followed up as an inpatient for 3 to 4 weeks, and then as an outpatient. The frequency of controls as outpatient is higher in the first, let's say, 3 months after the infusion of gene therapy, and is very variable based on the condition of the patient. But after the first 3 months, usually we can reduce the frequency of controls. Patients who came to our center from abroad were able to come back home. And so basically after the first 3 months, a patient can perform a blood test near their hometown. During the first year of follow-up, the immune system is still reconstituting because T cells, corrected T cells usually come out after the first 3 to 6 months. So we used to keep patients on antimicrobial prophylaxis for first year of follow-up, more or less, as well as on immunoglobulins. Then after first year of follow-up, in which we perform all the tests required to check that immune reconstitution is completed, then we can start to release prophylaxis and stop immunoglobulin and so on. So I tried to summarize very quickly, but
that was great. Thank you. Then there were a series of questions about what are the criteria to recommend gene therapy to patients at this time, and if you can speak to the age of the candidates as well. Are there different criteria for babies compared to adult patients with the disease?
actually, at the moment, there is no consensus on what is better between a match-related donor transplant or gene therapy. So I think that the decision is based on multiple factors. the indication is for all patients above 6 months, so there is no indication specific to age. So basically, I think it's a matter of donor availability, availability of gene therapy as well, and also patients and family preference. There are no data of comparison between bone marrow transplant and gene therapy at the moment, so we cannot provide what is best. But I think it's always good to have more than one option on the shelf in order to be able to choose the best for the single patient. One advantage of gene therapies compared to bone marrow transplant is that there is no need to give immune suppression as a GVHD prophylaxis in the first months after treatment, and also that there is no high level of reactivation of viruses in the very early follow-up, because there is no additional immune suppression on the top of ongoing immune reconstitution. And when we talk with the families before treatment, we also have to talk about the risks intrinsic to gene therapy, that are the risk related to insertional oncogenesis. That means the vector enters in the DNA of the cells near genes that can give rise to tumors, and this was a safety concern in previous trials using different vectors. Up to now, we did not have any signs of these risks, but it's important to keep monitoring that over time. And we keep monitoring that also in all the treated patients in order to be able to say that up to now, we haven't seen no signs of that. So, sorry, I talk too much.
No problem. This is great. Regarding the age again, have you seen differences in outcome that favor the younger age compared to older age? I don't know if you had adults treated yet or not. And as you know, in transplant, there seems to be a factor. Age seems to be a factor. In that case, the recommendation is to treat sooner rather than later. But what about for gene therapy?
Actually, we have treated 2 adult patients and a few adolescents. We have not seen differences in terms of outcome. I have to say that the only patient who died in our cohort was an adult patient. He was 35 years at treatment, and he died because of deterioration of this neurological condition that he had before gene therapy. And that was not related to gene-corrected cells, but we cannot exclude the role of conditioning regimen in deterioration of this condition. But the other adult that we treated was splenectomide when he was a child, and the outcome in this other patient was comparable to that in young kids. I think that it's a matter of I would recommend to perform gene therapy earlier in life, as in the HACT field, because of course, if you treat a patient with no organ damage, with no accumulation of disease-related complication, or the outcome, I mean, we have no demonstration that outcome is better, but the pathway is smoother, because of course, if you treat a patient which has collected autoimmune manifestation, immune dysregulation, also arriving to treatment is more difficult, because, for example, the patient that I mentioned before who had thyroid cancer, actually, he was diagnosed late in life, so he collected lots of disease-related manifestation, and he had a very bad autoinflammatory syndrome. We had to control it before giving the green light to perform a mobilization, because mobilization can trigger autoinflammation, also in patients without previous autoinflammation. And for example, another thing that we have implemented over the years is to give anakinra in patients with autoinflammation before collecting cells to control also inflammation, because an inflamed bone marrow is not a very good place for cells to engraft. So, and also to prevent clinical deterioration due to this autoinflammatory flare. So that was another implementation over the years. So I would recommend to treat patients as early as possible, as in the BMT unit, because to make things smoother, let's say.
Thank you. The next question is a little bit of an hypothetical, but the question was: is gene therapy going to be able to prevent the risk of cancer, autoimmunity, or to treat somehow patients or ameliorate complications like IgA nephropathy in patients that receive gene therapy after having already developed the disease?
I think the aim of the reconstitution of a functional immune system is, apart from preventing infection, also to prevent new onset autoimmunity and to improve immune surveillance for cancer. So as regards cancer, we need to keep following patients, because usually malignancies arise not very early in life, so we need to keep monitoring them to give proper answer to this question. As regards autoimmunity, I have to say that in the cohort of patients that we have treated so far, there were no patients with active IgA nephropathy. So but it was just by chance. It was not like an exclusion criterion. But if I have to think about the autoimmune manifestation that patient had before treatment, I'm thinking especially to IBD. We had some patients with IBD before treatment, and in all of them it resolved, apart one patient. But that one patient in which IBD recurred after treatment, I'm not sure it's only because of Wiskott, but because he has a family history of IBD also in non-Wiskott members of the family. So maybe it's more complicated in that case. But in most patients, ongoing autoimmunity before gene therapy resolved and did not recur. So I think that the correction of gene defect, and especially the reconstitution of wasp expression in lymphocytes, and especially in B-cell compartment, but not only in B-cell compartment, also in the innate immunity and in the T cells, help patients to be protected also from autoimmunity. But I think it's very important to keep following patient up in order to confirm this over a longer term follow-up. Also because a frequent question that I receive from families when we counsel them before treatment is, how long does the gene therapy effect last? And every time, every year, I can add 1 year, because of course, in bone marrow transplant, there is a longer history of observation or follow-up of patient. So, but now we are approaching the 16 of follow-up in the first year, in the first patient treated. So I think that every year we can increase the length of follow-up. But as far as of today, we have no clues that suggest like a loss of efficacy, because we keep seeing consistent results over time. But it's important to keep recording and following this patient up.
Thank you. Following up that topic with the question of what if gene therapy doesn't work? Does having a gene therapy process done, does that make other potential form of therapy more difficult in the future?
Fortunately, as of today, we do not need to perform secondary procedures, but I'm thinking about other diseases or also other trials in which it was needed to perform a secondary procedure, and performing gene therapy does not preclude it to have a allogeneic HSCT afterwards. So there is also always this kind of salvage therapy in case of need. So I don't think that this precludes. The opposite is more difficult, because I mentioned this patient that we managed to treat with gene therapy after multiple rejection of allo HSCT, but I would not, I mean, I think it's very patient specific, because we had another experience with, that was an adult patient who rejected the graft, an allograft, and reconstituted his own autologous hematopoietic system without receiving an autologous backup, and he failed to mobilize cells to be collected for gene manipulation. So at the moment, it's something that can be considered, but I will not take that for granted.
Thank you. Then there are a series of questions that I think are very important in regard the current role of gene therapy for what used to be called XLT, and for the new form of disease that are the carrier females that are symptomatic. What is available now for these two group of patients, and what do you see be available in the future?
Actually, starting to answer from kind of historic XLT patients, I think that with the current indication, they are approved by both EMA and FDA. They are eligible to treatment. And maybe I would not treat a patient at 7 months of age, like early to treatment, but I would not wait too much, because, for example, in our court, we treated the patients that in the first years of life, they were XLT, but then they developed the complication. And it's very tricky, because complication develop without telling you in advance. So then I think that if there is the possibility to get treatment also having only thrombocytopenia, I would go for treatment, because you never know when the disease will progress. And the data from the survey of Valli and colleagues clearly show that the risk of developing disease-related complication is always there. So I would at least consider the option. Then there are many factors to be considered, but it's easiest to treat a patient earlier in life without complication than afterwards. And as regarding female carriers, actually, we had no experience. We never treat females. But that is not a contraindication for treatment. So in case of heavily symptomatic carriers, I would consider the option.
But right now, the inclusion criteria or the exclusion criteria prevent treating?
No, of course,
they don't prevent treating
no.
Malaria, not carrier females.
No, the label is quite open. Of course, as regards females, we have to say that we have no experience.
Right.
But from the biological and scientific point of view, there should not be differences in outcome. But I have to be honest to say that we have treated all males so far. So there is limited, I mean, there is no experience, not limited.
And there is also a series of questions about availability of gene therapy. Where is it available in Europe, in the US, or do you in Milan accept patients that they come from countries outside the Europe and US where the Wiskirria has been approved?
So for the moment, there are still ongoing discussion about the price and reimbursement. So we are keeping treating patients in Milan under the 648 Italian law for the time being, because this kind of discussion about price and reimbursement take some times. So, but for the very near future, the only treatment center in Europe will be in Milan for the time being. I don't know for the future. And but patients from European countries can be treated in Milan through the S2 form, or like for Synvelis, for example. For a patient in the US, there are ongoing discussion about opening treatment centers in the US. I still don't have any confirmation about the number of treatment centers and which treatment centers will be open for treatment. But I hope that by the end of 2026, treatment will be available in the US. For extra US and extra European countries, at the moment, there are no official approved ways, but I think that there will be next, let's say, space for discussion, finding solutions. So I don't have an answer as of today, but we know, especially also Fondazione Teleton knows that it's very important to try to find ways to have treatment also for other countries, but at the moment is not available.
Thank you. We are already a little over the time. Can I ask a couple more questions to Mati? You're muted, but you said
yes, sure. If Dr. Farua is okay with it, if she doesn't mind staying a little over. Thank you, Dr. Farua. Thank you, Dr. Kendari.
So one very interesting question was that of whether a successfully treated patient can himself or herself at some point be a donor for a family member, an affected family member.
Actually, it's a very interesting one, but the answer at the moment is no, because the label of Wiskirria is, I mean, for patients treated is not allowed to donate the tissues or cells. Also because we don't have demonstration that that would not actually work, but probably those stem cells would have been stressed too much. So we would not recommend it, but I would suggest in that case to treat directly the patients directly with gene therapy with his own stem cells, because the process would be probably too stressful and also too risky with the information that we have at the moment. I mean, to donate cells.
Yeah. Okay. Let's see.
Also, because sorry for interrupting. Also,
No
because
problem.
maybe in the bone marrow of treated patient, there is a combination of cells. Some are corrected, some are not corrected. And the not corrected one maybe are those who have been exposed to chemotherapy. So maybe they would have, the one who may be too stressed to go from one patient to the other, let's say. So this is something that should be considered also.
Yeah, absolutely. I'm looking at the chat to see if there are other questions. I think we have explored more or less all the topics and all the main line of questions that we received. And I think we'll probably stop there. So, Mati, do you have any questions that I missed?
No, I think we were okay. I think we were okay. I think there was one patient who had a question about two transplants and potentially having gene therapy. I think you answered that question for the most part, about there
I,
being.
sorry, Sumati, just read that a question pop up on the chat now. What happens to uncorrected cells? Basically, what what we have seen is that having a chimera of corrected and non-corrected cells, with most of the corrected cells there, being corrected cells, sorry, having a corrected cells an advantage over non-corrected cells, that, let's say, they live in peace together. I don't know how to explain that in other words. Is different from the chimera that is in the bone marrow transplant setting, which there are recipient and donor cells, in which sometimes there is kind of immunological fighting. In being the cells of, in any case of the patients, there is no immunological conflict between corrected and non-corrected cells.
Perfect. So there were two questions that were outliers that I wanted to ask. One was a family, if the father is a patient treated with HSCT and the mother is a carrier, and if they have, say, a daughter who has both both X's are now mutated, would the gene therapy correct it?
Basically, we don't have patients like that in our court, so I cannot base my answer on like evidence. But in principle, yes, because in gene therapy, you with the vector you add a copy of the corrected gene. So in principle, in that case, it would resemble gene therapy for autosomal recessive diseases, in which you have the two alleles with the two altered copies of the gene, and you correct with the vector bringing a correct copy. So in principle, that would work.
Thank you. And we have one family who's had two transplants and waning chimerism, and they wanted to know if anybody in the world has had three transplants, or if they can have gene therapy.
The problem is that the patient should have no cells of donor origin around. So I know that's a pain, because if you have little, maybe that's not enough to correct the disease phenotype, especially if the myeloid chimerism is like totally recipient. But we cannot, I mean, gene therapy is contraindicated in cases donor cells are still around. So the patient that we treated had zero donor cells around, incredibly. We are following that patient really closely, but before starting the process, we demonstrated the absence of donor cells, not only in peripheral blood, but also in all bone marrow cell lineages, because we had to be sure not to correct the donor cells.
Perfect.
That would have been
That's great.
not
Thank you.
ideal.
Thank you. I think we covered, I think you covered everything, Dr. Kendari. I think you got the range of questions pretty much through, and with Dr. Farua's talk, I think we're done. If we can, is it okay if we close now? I just would like to share some information. Let me see. Perfect. So before we close, I just wanted to say we might have a session in May, but in June, I wanted to invite everybody. We already have 23 families who have registered. Registration is still open. Please join us for the Wiskott session at the IDF National Conference. We actually have a dinner on Thursday just for Wiskott families and the speakers. But on Friday, for 3 hours, we get to spend time with Dr. Kendari, Dr. Farua, and Dr. Sangyan Pai, where they will be talking about the new guidelines in management for WAS. The new global consensus is happening as we speak. It's actually done. We're writing it up as we speak. And there are changes in For example, XLT will no longer be called XLT, etc. And they will discuss indications for transplant and indications for gene therapy, and also discussion on female carriers for WAS. So all of these are relatively new topics. So please join us. Those who haven't signed up, please sign up. It's a fantastic opportunity to hear from these amazing speakers. And on Saturday, you'll actually hear a Rare Connections story from a WAS GT family. So a lot of exciting things. So please join us. And with that, I just wanted to say a huge thank you to all of you who've come at all hours of the day to join us for this meeting. And of course, to Dr. Farua and Dr. Kendari for their time, taking their time on a weekend to come and share this information with our families. We could not do this without our board of volunteers. Mike Swinicki is here, Amy McNally, who helps with all of the logistics, and Brandon, who helps with the recording and the webinar afterward, the putting out the webinar afterwards, and of course to our donors. None of this would be possible. So thank you all for joining us on this beautiful Saturday, and we will see you with the next webinar.
All right. Thank you, Sumati. Bye,
Thank
everyone.
you, Sumati. Bye-bye. Thank you,
Bye-bye.
Fabio.